Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, an update on sickle cell disease. Dr. Mark Gladwin is Dean of the University of Maryland School of Medicine and one of the nation's leading sickle cell experts. He joins Dr. Josh Sharfstein to talk about exciting new treatments for this serious condition, including gene therapy that provides a lasting cure. He also discusses the challenges to making effective treatment fully accessible to all who can benefit. Let's listen.
Dr. Mark Gladwin, you are one of the nation's experts in sickle cell disease. You have devoted much of your career to researching this condition, to studying treatments, and to writing the leading textbook on sickle cell disease. Thank you so much for joining me today on Public Health on Call.
Oh, thank you so much, Josh, for having me here.
So I want to start with a pretty basic question. Could you just remind me and our audience, what is sickle cell disease?
So basically, it's a genetic disease that affects red blood cells. And people that inherit this disease have an abnormality of their hemoglobin, which is the protein that fills our red blood cells. And that's the protein that carries blood and essentially it's part of blood, but it carries oxygen from the lungs to the body. And when you have this disease, that hemoglobin can polymerize or crystallize or sort of stick together and ultimately leads to abnormally shaped red blood cells that have a sickle shape and can block blood vessels and lead to many, many complications.
So without any treatment, what is someone with sickle cell disease at risk for?
So again, the disease manifests at about 6 months of age. And so there's different presentations at different stages of life. Nowadays, usually through neonatal genetic testing, we know which baby will have sickle cell disease. But starting at about 6 months, the baby will fail to thrive, will have pain, can develop swelling of the digits called dactylitis. And during childhood and at 5 years of age, they're at very high risk of strokes. And throughout the entire lifespan, there's episodes of severe pain. And the pain can affect all parts of the body, but typically bone pain, back pain, limb pain, chest pain. And that's caused by these sickled red blood cells blocking blood flow and creating ischemia to the bone marrow. And throughout life, there's other complications that develop that we could discuss.
You know, I'm a pediatrician. My pediatric training, I cared for a number of patients with sickle cell disease, and the pain crises that I saw were some of the most horrible things to witness, and you could really just see the tremendous amount of suffering.
Yeah, if any of your listeners have migraine headaches, I consider this sort of a migraine of the entire body. A migraine headache is a vasoconstriction or a vasospasm of the blood vessels to the brain. And sickle cell disease, you're blocking blood flow to almost any organ in the body.
Talk to me a bit about who has sickle cell disease.
So first of all, it's a genetic disease. It's one of the most common of what we call monogenetic diseases in the world. And it's a autosomal recessive disease, meaning you need to inherit 2 copies, one from each parent, to have the disease. This genetic mutation occurs in areas where historically there were high rates of malaria. So particularly in sub-Saharan Africa, Southeast Asia, the Middle East, these areas tend to have these sickle cell mutations. So in the United States, we see a lot of patients that are African American because of that ancestry. For example, among African Americans, there's about 8% of the population carries one of those mutations. And about 1 out of 500 babies born to African American parents will have the disease, will inherit both of those gene abnormalities or both of those mutations.
So we have a pretty common genetic disease, as genetic diseases go, and it's predominantly affecting in the United States Black Americans. How has treatment progressed for a very severe disease like this in the United States?
So I think there's been a series of important discoveries and treatments that have improved the survival of our children in the United States born with sickle cell disease. And just to jump to the punchline, the median survival today is 42 years for men and 48 for women. And many people are living a full lifespan with sickle cell. But these breakthroughs start with therapy in children, starting from penicillin in babies and young children to prevent infections, vaccination, all the great things to prevent infections, because these infections trigger severe sickling and vaso-occlusion. Also, we know the children at highest risk of stroke, we can identify them with ultrasound and treat them with blood transfusions. The next big breakthrough is a medicine called hydroxyurea, and we have to mention that medicine because it's generic, it's cheap. It was discovered through research funded by the National Institutes of Health, and that pill, we now know that works in babies, in children, in adults, and it reduces the frequency of pain crisis and improves survival. And finally, I think we need to talk about this in a little more detail because people will be interested in it, so I'll only briefly mention that there are now curative gene therapies that are very exciting and has sort of captured the attention and imagination of the world.
I remember when hydroxyurea became available and some of our patients who had a lot of pain crises suddenly stopped coming to the emergency department. That was a huge leap forward, but the concept of a cure is really remarkable. Could you explain a little bit about how these therapies work?
So there's really two FDA-approved curative gene therapies now. And maybe before I mention that, I just want to point out that good old-fashioned bone marrow transplantation is curative. And if you have a child with sickle cell disease and you have a perfect sibling match for a bone marrow transplant, that is the way to go. That is very safe and there's a cure. And there's another form of bone marrow transplant that really was discovered at Johns Hopkins University, where I know you work, and that is a haploidentical bone marrow transplant. So there are bone marrow transplantation strategies. People are very excited now about these new gene therapies. Now, both of the approved approaches, and I'll briefly mention them, both of the approved approaches still require a bone marrow transplant. But instead of receiving a bone marrow from your sibling or from a parent, you would donate your own bone marrow. We would collect your stem cells, and we would then target those stem cells with a gene therapy intervention, and we'd make sure those cells are safe and good and that the gene therapy worked. And then we would give you an autologous bone marrow transplant, meaning we would ablate your bone marrow and give you your own bone marrow with the gene therapy back. But it's still what we call a myeloablative bone marrow transplant. The advantage, it's your own bone marrow, so you're not going to have rejection or maybe the rejection-related complications.
So just so I understand, you were talking before about the 2 copies of the gene that someone has to have to get sickle cell disease. How do these gene therapies actually work in the lab before they're brought back through a bone marrow transplant into someone's body?
So let me walk you through the 2 approaches. One of them is you take, let's say you have sickle cell disease, Josh. We would do what's called a pheresis, and we'd collect your stem cells, and we would culture those stem cells. And then what we would do in one version is we infect your stem cells with a viral vector. So it's truly gene therapy. And in that viral vector, we place a copy of the normal hemoglobin gene for the beta globin. Now, it turns out they were a little more clever. They made that replacement, they put another extra mutation in it that had a little more anti-sickling properties. It tended to interfere with that hemoglobin polymerization. But so that's a viral-based vector replacing, putting a new copy of the normal beta chain of sickle cell disease. And so you're going to express a high level of that anti-sickling normal beta globin. The second approach has got everybody really excited and led to, though probably contributed to the awarding of the Nobel Prize recently in physiology and medicine. And that was what we call gene editing. And that uses this thing called CRISPR-Cas9 gene editing. Now, what they did there is they didn't actually edit the abnormal sickle cell mutation. They didn't replace that single polymorphism. But what they did instead is they knocked out an enhancer. I mean, it's complicated, but for the scientists, they knocked out an enhancer of a transcriptional repressor called BCL11A. And when they do that knockout, the BCL11A levels drop and the fetal hemoglobin levels, which is an early fetal version of hemoglobin, increase.
Right.
So in people with that editing technique, their stem cells will now make a lot of fetal hemoglobin. And fetal hemoglobin also inhibits that hemoglobin polymerization event. I'd love to see a pure editing event, but these were the two approaches.
Somewhere in the deep recesses of my memory, I recall that hydroxyurea might cause a slight bump in fetal hemoglobin. Is that correct?
Absolutely. You know, hydroxyurea, we think of it as a really mild chemotherapeutic agent, but hydroxyurea reprograms our DNA to make the fetal version of hemoglobin, which doesn't have the mutation. So if you take hydroxyurea, your fetal hemoglobin may go up to 5, 10, 15, 20%. And what we've discovered is that people that have very high levels of fetal hemoglobin, if it's over 25% in every cell, they don't get sickle cell disease, even though the rest of their hemoglobin has the sickle mutation.
Okay.
And interestingly, we learned that because there are populations of people that have a condition called hereditary persistent fetal hemoglobinemia, and they have high levels of fetal hemoglobin. And so that CRISPR gene editing technique essentially made a cut, knocked out the enhancer that was the same enhancer knockout in those people with persistent hereditary fetal hemoglobin. So I know it's a little confusing, but that's how it works.
I think it's fascinating. And what you're basically saying is there are a couple of genetic strategies, one of which is to create more normal hemoglobin with a little extra to prevent the sickling. And the other one is to essentially generate more fetal hemoglobin, doing even more than what the hydroxyurea treatment does.
Absolutely.
So let's switch gears, because part of taking care of patients with sickle cell disease is having the treatments that can improve their health and even cure. But the other part is actually getting the treatments to people. And this is where our country hasn't done so well. Could you talk about some of the gaps in treatment for people with sickle cell disease in the United States?
Absolutely. You know, maybe I can say a little bit about what we're doing well.
Okay.
And what we're not doing well.
Sure.
And I think what we're doing well is that we're doing really well with universal genetic testing of babies. So even if I have a baby, my babies were tested for sickle cell. So we're identifying the babies that have sickle cell disease at birth, and that means we're prepared. We prepare the parents. We educate the families. That baby can be enrolled in a comprehensive sickle cell center and program. We can pay a lot of attention to vaccination, hydration, good nutrition. All those things make a huge impact on preventing severe vaso-occlusive events. So we do that well. Second thing I think we're doing really well more and more is treating young babies and young children with hydroxyurea. There was a big study called Baby Hugs, and it showed that if you give your baby hydrea as an elixir, the fetal hemoglobin goes high and stays high. And we're seeing better growth, performance in school, less crisis, really dramatic. It turns out babies and children respond to hydroxyurea even better than adults. And if you look at most centers of excellence, 70 to 90% of the children are taking hydrea. So we're doing good with that. The other thing we're doing pretty good at, and you have to go to a center of excellence, is screening for stroke risk. And if you have a high risk of stroke, which is a horrible complication of sickle cell, and it happens at age, 3 to 7, and we're giving them blood transfusions and preventing stroke. We start to struggle with our adult patients. Prior to the Affordable Care Act, you could turn 18 and sickle cell is a pre-existing condition. You could lose your coverage and insurance just because you were born with a genetic disease. So in my lifetime, there was tremendous challenges providing comprehensive high-quality care to our adults with sickle cell disease. And that was magnified by a perception that our patients were pain-seeking, opioid-seeking, which, this was a disease like migraine where there's horrific pain. And we also had socioeconomic, health inequities, and I think really systemic racism and how patients were treated in our emergency rooms, and just terrible, terrible care from 18 on up. I think that's really improved now with the Affordable Care Act, because everyone with sickle cell will have access to insurance, and that's made a big impact on the quality of care for adults. But there's still, these therapies are expensive, and we have to develop centers of excellence, community engagement, overcome trust issues, build teams and partnerships with our patients. And we've even tried to work together with our patients, changing the language around stigma, that our adults with sickle cell are warriors. They've had to overcome these challenges across their lives to survive having sickle cell disease. So those are some of the positives and negatives, I would say.
I appreciate that discussion. Are you worried that people who could really benefit from these new therapies may not be able to get them?
Yeah, so that's another big challenge. These discovery of gene therapy for sickle cell with that lentivirus, special hemoglobin, or the CRISPR-Cas9 gene editing, these are revolutions in science. I mean, I cannot, but for our listeners, it's breathtaking, these discoveries. And again, Nobel Prize awards. And I'm proud that this was NIH-funded research conducted in the United States and taken all the way to FDA approval. The problem is the price point on these drugs. One of them is $2.2 million and the other is $3.2 million. And, we're about, at the state of Maryland, we have 2 patients that are having their stem cells harvested for curative gene therapy. So we're very excited about this at the University of Maryland, that we're offering this therapy for our patients. But that's very expensive. And so how that plays out in the market with coverage, et cetera, is going to be a challenge. And, part of the pricing is they're saying, well, the development costs and the savings of not having sickle cell for the rest of your life. But those high prices are creating many barriers toward the widespread access to those curative therapies. Mm-hmm. I just have to say one thing, Josh. I was at a conference at the New York Academy of Sciences. I was giving a presentation about adult complications of sickle cell, and we had a panel, and we had 2 patients that had received curative gene therapy. And it was amazing hearing their stories. I mean, one thing they told me is that they didn't realize, even though they had really aggressively treated their sickle cell with hydroxyurea, they'd done all the right things, they said their energy level, once they were cured, they said they had never realized how much energy that was expended just day to day, making new red blood cells, dealing with sickle cell. They had enormous energy. Their pain went away. It took a while. I mean, a lot of this is chronic pain, so it almost took 6 months for the pain to go away, even after cure. But it was just fascinating hearing their stories and how good they felt.
Well, I mean, when you said before that, we're making progress, life expectancy is in the 40s, I was thinking the 40s,
Right.
That's terrible. So there's so much room for improvement if more people can get therapy that can actually cure their disease.
Absolutely. And when you look at hydroxyurea, for example, only about 50% of adults take the medication. Some of that is that they don't tolerate it. Some of it is a fear of long-term safety issues, which really haven't been borne out in our trials. We can't take it if we're going to be pregnant and have babies, so there's that. But the utilization of hydroxyurea is lower than we want. There were also 2 other drugs that were approved, which was very exciting. One was a adhesion blocker, a P-selectin blocker, and the other was an anti-polymerization drug called voxelotor. Both were approved, but when voxelotor was taken to clinical trials in Africa, there were deaths, and Pfizer withdrew the drug from market. Yeah. The P-selectin had a second confirmatory trial that was worldwide, and it was not a positive result, and so that drug was pulled from Europe. It's still approved in the U.S., But so those two drugs, we were very excited that maybe we were on the verge of triple therapy. You could take hydroxyurea, voxelotor, the P-selectin blocker. But unfortunately, that was a setback in the last year. So I think our adults are still looking for what we see in heart failure. In heart failure, you take four drugs, the 4 pillars of heart failure care, and you can live a normal life. We need that kind of medical therapy for sickle cell, and we do need, more affordable gene therapy. But I think these things will come with continued support and investment.
I hear you saying we want treatment for everyone, and then the people who are making the decision to do gene therapy, they should have access. Let me just ask you, given the disappointment that has been experienced because of some of these medications not doing as well as hoped, are you worried about that for the gene therapy? Do you think there could be complications we haven't seen because these treatments have just started? How confident are you that this initial incredible promise is going to be realized?
Well, so first of all, we have follow-up that's, first of all, for bone marrow transplantation, I always want to keep bringing that up, but for a perfect sibling match bone marrow, we have decades of experience. It's curative. If my child had a sibling with a perfect match, that would be the way to go for a normal life. Haploidentical transplant, we now have a lot of experience. 2 major trials were published. It looks extremely promising. So for people at high risk, that option is available. And then gene therapy, I think we're using these therapies in people that are having more complications, more pain crisis, the acute chest syndrome, young adults, teenagers, and adults with a lot of complications where that risk benefit suggests that it is worth going for that cure. Plus some people, hey, I want to be cured. I'm ready to move beyond this. And those individuals have that option. But I do think for folks that are sort of waiting to see how this plays out and a little more time, again, we can be really aggressive with hydroxyurea therapy. And there's a lot of options to improve outcomes. There are blood exchange transfusions. I lead a major trial in 22 sites in the US and Europe of a full automated blood cell transfusion where we remove the sickle blood and put new blood in every month. Wow. And that trial has about 6 more months, but it will be very interesting to see an important result to know whether that works. So there are other therapies available short of gene therapy, but so far with the gene therapy, we have more than 2 years of follow-up, and it looks quite promising.
Great. Well, bottom line, after many years, some major progress is happening for patients with sickle cell disease, but we have to make sure that there's access to care. Otherwise, all the benefits of this research doesn't translate into lives saved, better outcomes, and greater health.
Absolutely. In the vast majority of individuals with access to preventive care with Hydrea, access to expert care during that vulnerable crisis, and a lot of the therapies that have been proven to work, like blood transfusion in children at highest risk of stroke, hydroxyurea in babies, children, and adults, these things have a significant impact on preventing these pain attacks and these complications.
Well, Dr. Gladwin, I have a feeling we could talk about sickle cell disease for a few more hours, but our time is up. Thank you so much for talking about the promise and the urgency of getting the best advances in science to the patients who really can benefit. Thank you.
Thank you, and I appreciate the opportunity. I do want to throw in that I am a country lung doctor. I'm not a hematologist. So while I've spent my life on sickle cell disease, you probably could have found a better expert, but I appreciate the chance to speak about this, something I'm very passionate about.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.